Hi, my name is Karen Humphrey, and I'm here with Lizzie Wehling, and we are doing a presentation on injury prevention for the foot and ankle as part of the Safe Play Enrichment series for District 20. A quick little bit about myself. I worked for UCHealth for just about 5 years. I went to school to be a physical therapist, and then I got my orthopedic certified specialist for the first time in 2007. I have a passion for injury prevention, especially in the teenage athlete. I am currently enrolled at the University of Montana to get my doctorate in physical therapy. I recently switched, though, to working still for UCHealth, but at Memorial North Hospital last year in December.
And my name is Lizzie Wehling. I am a physical therapist also with UCHealth. I've been here for about 10 years. I graduated from the University of Columbia in 2011 and got my orthopedic certification in 2019. I have also been working as the last 2 years as the rehab orthopedic lead for our department, focusing on program development and growth and education in orthopedics. Same as Karen, have lifelong interest in sports and injury prevention, having been an athlete my whole life. So we're excited to be here today to talk to you about injury prevention for the lower extremity. So just to review our objectives here, our objectives are to review the incidence and prevalence of lower extremity injury in high school sports participation, to discuss the impacts of lower extremity injury on student athletes, to review risk factors for lower extremity injury in student athletes, to present evidence to the benefits of lower extremity injury prevention, and to present some general concepts and outlines of injury prevention programs for both the foot and ankle and the knee. So to kick us off, just to discuss a little bit the incidence and prevalence of lower extremity injuries. So this is really a big problem in our country. An estimated 12 million student athletes between the ages of 5 and 22 years sustain a sport-related injury annually. In the US, these injuries account for an estimated 2.6 million visits to the emergency room by children and young adults. As young adults reach puberty, the injury rate for youth sports increases, and female athletes who specialize in one sport are more likely to sustain overuse injuries than their male counterparts. For the lower extremity, over 40% of sports-related injuries occur at the knee or ankle. So today we're going to be discussing primarily ankle sprains and ACL injury, but a big chunk of these sports-related injuries have to do with the lower extremity. To speak more specifically to the ankle, so the ankle is the most commonly injured area in high school sports participation, with about 22% of high school sports injuries having to do with the ankle. Football, soccer, basketball, and volleyball have the highest incidence. So those sports that have jumping, cutting, and running are the ones that tend to have the greatest incidence of ankle injuries. These ankle injuries are most often sprains, lateral ankle sprains, but also include fractures, ligament tears, and contusions. So you can see here in this chart down here, ankle injuries by type. You're looking at about 83% of these injuries being sprains, 5% being fractures, 4% being full ligament tears, and a smaller percentage of that being contusions. Ankle sprains often require less intensive treatment, these lateral ankle sprains, than some of the other fractures or full ligament tears. However, the history of a lateral ankle sprain can predispose an athlete to a recurrent injury in this area.
Now we're going to go into the incidence and prevalence of the knee injury. It's been consistently documented that knee injuries account for about 15% of all high school sports injuries. One study that I found that accumulated data for about 10 years found that 21% of knee injuries were treated with surgery. And girls were more often to be treated with surgery than boys in their gender comparable sports. Knee injury rates are highest among football players and women's soccer. And what I've done here is, this is a graph of just the knee injuries by type. So you can see that out of all the knee injuries, the MCL, which is the medial collateral ligament, that's the big ligament that runs kind of on the inside of the knee, is the most commonly injured. However, it's not often or very rarely needs surgical repair. And you'll see here the third most injured is the ACL, and that one is definitely one that's common to have surgery. So we kind of will go into the focus on that later in the slides too, just kind of for prevention of that injury so surgery could be avoided. And I'm kind of jumping off that last slide. The ACL, or the anterior cruciate ligament, affects as many as 250,000 individuals in the United States annually, and that's adults too, but just kind of wanted to give you an idea on how common it is for people to injure their ACL, and that can lead to healthcare costs annually of $2 billion. The incidence of ACL injury is greater in males due to their exposure. Males in general are exposed to more things that would injure their ACL. However, the relative risk of females, meaning a female that's exposed compared to a male, is 2 to 8 times greater of getting an ACL injury compared to a male, the male exposure. And there are many different things you can read about on why this is the case, but the 4 most common things that I found and why females have that greater risk of injury is kind of the 4 main things I found were their ACL ligament itself is smaller. In general, especially because of hormones, females have increased laxity or looseness in their ligaments. Females often have different landing mechanics, and that's kind of the basis for a lot of the prevention programs that we'll go into later towards the end of this lecture. And then in general, although I think this is changing, females just aren't strength trained as well as the male counterparts, but I do think that as these ACL prevention programs take off, that's going to change, and maybe that won't be one of the higher risk factors for females.
Okay, so moving on to sort of what is the impact of these kinds of injuries. Looking at the ankle, most ankle injuries are going to result in some missed playing time. So the majority, 51%, are going to result in sort of less than 7 days missed time. About a third will result in between 1 and 3 weeks worth of missed time, and about 10% will miss more than 3 weeks of their playing time. So if you're thinking about a short season like volleyball, or one of the other sports that has a shorter season, that can be a pretty significant chunk of the season missed because of an ankle injury. Following an ankle injury, we start with a physical assessment, which might be done by an athletic trainer, might be done by a physician provider in the emergency room or at your normal doctor's office, or it could be done by a physical therapist. Following the assessment will determine the need for whether or not additional imaging is required. That might include an X-ray, depending on whether there's a potential risk for fracture, or an MRI if there's a potential indication that there may be more significant ligamentous damage. Following injury, the interventions kind of start with what we expect after sports injuries. So we start with the rest, ice, compress, and elevate, trying to keep you off of that ankle or keep your athlete off of that ankle to allow things to heal, allow some of that inflammation to calm down, and that healing process to occur. Rehabilitation is recommended after ankle injury. Athletic trainer or physical therapist might be involved in this. Typically, following a pretty uncomplicated ankle sprain, they'll look like about 6 visits. Manual therapy is really strongly indicated for these individuals, along with potentially taping or bracing. And then really important is the strengthening and neuromuscular retraining. There's a lot of evidence that demonstrates that strengthening and neuromuscular retraining following ankle injury is hugely important in preventing re-injury. Looking down the road, if you need more severe medical or more intensive medical interventions, you could think surgery or injections. Surgery is very often or is only indicated in individuals who have long-standing chronic lateral ankle instability and also those who might have a more significant ligamentous injury or fracture. The long-term risks of ankle injury include recurrence of ankle sprains. So after an ankle sprain, you're twice as likely in the 12 months following to re-injure that ankle. Another thing that can happen is chronic ankle instability. Many individuals who we see in the clinic later on have had ankle sprains since they were in high school and end up having recurrent pain and issues limiting their ability to participate in sports and recreational activities following their athletic careers. And then, of course, leading to potentially the development of degenerative changes later in life, thinking arthritis, or again, some of those things that might predispose someone to needing ankle surgery later on.
And now I'm going to go into the impacts of the lower extremity injury for the knee. And on this slide, you'll notice a lot of detail about the ACL. And again, I'm providing more information on this just because it is commonly fixed surgically. So there is a lot of information out there on what kind of impacts that have on the student athlete. So complete ACL injuries can lead to chronic knee pain, damage to other cartilage and ligaments, as well as instability of the knee. So you have that ACL injury. These things are sort of like a cascade effect on that initial tear of the ACL. Individuals with reconstructed ACLs, meaning they had it surgically fixed, are more likely to have early onset arthritis and other degenerative changes to the knee when they get older. Post-operative rehab for an ACL reconstruction can take at least 6 to 9 months, which can lead to two things. It's going to delay their return to sport, and it could prevent them playing at the prior level just from the missed time in general from being out of their sport. Injury in a younger population, as you can imagine, is concerning due to the skeletal development that's still going on and the risk of long-term growth problems in those bony related injuries near the growth plates. Knee injuries can cause serious physical and economical burdens on the athletes. ACL reconstructive surgery can cost over $5,000, and that number obviously will continue to rise as healthcare costs increase. So now I'm going to go kind of in general on how we define the risk factors for lower extremity injury or leg injury in general. And then we'll go, the next few slides, we'll go into more details, kind of teasing out knee versus ankle, because they are a little bit different. Research historically has focused on anatomy, hormones, environment, and biomechanical factors. And biomechanical factors are just kind of defined as the mechanics of the person and the perpetrating injury and how what kind of went wrong to cause the injury to happen. Recent years, though, the research has grown to include many more factors due to the rise in information and people studying this and looking at this and what can we do to change to make these less likely to happen. There's a lot more research out there too on the injury prevention programs, which give us more of an idea of what the risk factors actually are. So now they have two categories for risk factors. There's extrinsic risk factors and intrinsic risk factors. And extrinsic risk factors are big things like the environment, the playing surface, even the level of the player, like how high a level of an athlete they are, as well as bracing and taping of the joints and areas of the body. Intrinsic factors are more personal, and they're much more in depth. And they're including things like the muscle performance, and the strength and the balance of the individual, and the flexibility as well as the endurance. So all these different things that are somewhat changeable from athlete to athlete, and kind of where they are with these things when the injury happens. And these risk factors, these intrinsic risk factors, are the basis of the research for injury prevention, which, as you can imagine, shows that stronger muscles and improved flexibility can offer protection from that injury throughout the season.
So looking a little bit more deeply into some of these intrinsic versus extrinsic risk factors for the ankle, some of the most clearly identified intrinsic risk factors include limited ankle dorsiflexion range of motion, which is just how much you can bend your ankle or flex those toes up towards the ceiling. Impaired proprioception and balance, talking about difficulty with neuromuscular control at the ankle, understanding joint position sense, and then balance, single leg balance and dynamic balance on different surfaces. A history of previous ankle sprain, as I stated earlier, has a huge impact on the likelihood of additional injury. There is some but less evidence for individuals with lower BMI, decreased strength and coordination, and decreased cardiorespiratory endurance being at greater risk of ankle injury. And there's no real increase or decrease in risk, male versus female, unlike the ACL. We don't really see a big difference between the two genders. Some of the extrinsic risk factors that can play a role here are sport requirements. So there's increased risk for ankle injury with sports requiring jumping, sprinting, and cutting. Playing surfaces, actually an increased risk on grass versus turf surfaces. Increased competition level. So what I mean by that is older students who are competing at a higher level may be at a greater risk than those younger students who are not competing quite as intensely. And then in competition versus practice, there's evidence in all sports except for volleyball that there's a greater risk of injury during a competition than in a practice. The presence of bracing or taping. Bracing or taping has been shown to be really effective in decreasing ankle injuries. So the bracing and taping or lack thereof may play a role. And then participation in a dynamic warm-up and balance and proprioceptive program. I think this could probably fall into both intrinsic or could fall into either intrinsic or extrinsic, looking at the balance and stability of the student's ankle, but also looking at what their coach and what their team has time to do. Participation in that dynamic warm-up can be a big improve or can help to decrease the risk of ankle injury.
So now I'm going to talk about the same two ways we identify the risk factors for the knee. Unlike the ankle, the intrinsic risk factors for the knee are female greater risk than male. The muscle balance ratio. So this one's interesting. It's the quadriceps or the front thigh muscle in ratio to the strength of the hamstrings or the back thigh muscle. So too strong of quadriceps in ratio to weakness of the hamstrings in the back of the thigh. So that's kind of another one of the basis for the prevention programs that we'll go into in a little bit. This is something too that is also interesting, the weakness of the hip in the core muscles. So not really necessarily the knees so much as the core and then upper thigh and hips has an impact because the instability of these muscles can cause more forces on the knees, especially when there's a jumping or a landing or cutting going on in the sport. And the landing mechanics, again, we'll go into more of this later, but the landing with locked knees or landing with the knees pointing towards each other, kind of in a knocked knee position, increases the risk of injury. The extrinsic risk factors are categorized as either contact or non-contact. So for the ACL, 70% of those injuries are what are called non-contact. The athlete turns, pivots, and lands kind of in a different position and injures their ACL. Versus 30%, which are contact, meaning there's a direct blow to the leg that forces the athlete to turn and pivot, and therefore the ACL tears. So most of them are not contact. Most of them are happening just with the landing or the turning that's going on in the sport itself. The playing surface is opposite of the ankle. The turf increases the risk for the knee injuries. And this I thought was interesting too, dry weather. So there's increased friction, which allows the foot to get stuck when pivoting or cutting. And this slide is one that we're going to go into on the evidence for injury prevention programs. Studies have shown a reduction in the lower body injury rates using training programs that focus on the things we kind of mentioned earlier, the landing mechanics, balance training, the strength training, and the agility training. It's been shown that prevention programs should start at or before the onset of puberty to prevent those poor patterns in the lower body mechanics. And then it should be stressed also to the student athlete that these programs, participation in them, would decrease the risk of a season-ending injury as sort of a motivation to participate in these exercises that could really help them go strong through the season and not have to miss out on the sport because they have an injury.
So looking at ankle injury prevention programs, so ankle injury prevention programs primarily focus on the prevention of lateral ankle sprains, which again make up about 80% of these ankle injuries in this population. Bracing and taping are hugely important for preventing ankle injuries. So bracing and taping can decrease the risk of lateral ankle sprains by 50 to 70%. Bracing is actually recommended over taping because the overall cost over time is lower and the application is less variable. Proprioceptive training, and the reason why bracing and taping can be helpful is because of the mechanical support that they prevent, but also, and more importantly, the neuromuscular control or the sensory impact that they can have on those muscles around the ankle can be significant in helping a student athlete correct before an injury or be more stable through their ankle. Proprioceptive training is also very important. So again, balance and coordination training programs are effective in preventing ankle injuries and are especially important for those who have suffered a previous ankle injury. Looking at balance and coordination training programs, some of the evidence shows that the numbers needed to treat are 17 for kind of all athletes and then 13 for those who have suffered a previous ankle injury. And what that means is that if you have a team of 13 individuals, you are going to be able, or you may be able to prevent an ankle sprain for one of your athletes by doing a balance and coordination training program. These can decrease injury risk by 30 to 45%. Looking through the literature, there's not a lot of specific set programs for ankle injury prevention. Most programs focus on balance, coordination, and reaction time using things like a wobble board, a foam pad, balancing with your eyes closed, standing on one leg to toss a ball, those kinds of activities. It is interesting that the longer a program is performed, the more effective it is. So the risk for ankle injury can decrease from year to year with participation in one of these programs. This goes back to what Karen spoke about earlier, where we're recommending that student athletes start these programs early on because they can have a cumulative effect over time. Here's just some examples of some proprioceptive ankle exercises. So you have someone standing on a piece of foam on one leg, someone doing a little bit of a weight shift or kicking their leg while standing on the foam to try to challenge that balance a little bit. Standing on one leg, turning from side to side, again, sort of mimicking some of those more sport-specific activities. Doing some squatting and reaching outside of your base of support while maintaining balance on one leg. And then some perturbation and jumping type activities that can help to improve the stability and proprioceptive or neuromuscular control of the ankle to help to decrease ankle injury.
So now this is the fun part. This is what you've been wanting us to get to. We're going to talk about some specific knee injury prevention programs that are out there, because there's definitely a lot more research on this than for the ankle. So a lot of the programs out there, though, focus specifically on ACL and ligament injury prevention. There are approximately 36 programs in the literature, but only a few have taken the steps to prove that they can really actually decrease injury. And the American Academy of Orthopedic Surgeons found that 2 programs that have, out of these 36, there's 2 programs that have significant impact on reducing the non-contact ACL injury rates in females. And remember, that was about 70% of the ACL injuries are from non-contact mechanisms. So there's the 2, we'll start with the 2 that they talked about, and then I have a third one that I want to present on too. But the key is any of these, a successful program includes a dynamic warm-up, supervised, purposely in bold, plyometrics, strength training for the hamstrings, hip, core, and trunk, and we talked about the reasons for those earlier. And then again, supervised agility training for cutting and pivoting. And I think I'll kind of reiterate enough, like the mechanics of how the athlete performs these exercises is super important. If they perform them wrong, they're practicing them wrong, and then they're not really helping themselves in the end. So we'll talk about how each of these programs too incorporates that supervised piece of what they're doing for the exercises and the things in the program. So the first one we're going to talk about is the first one that I listed back there, which is the PEP program. And this one was based on soccer players. So it's a soccer-oriented program. However, the exercises are universal for all cutting and pivoting athletes. This one and then the third one I'm going to talk about are similar in that it's a 15 or 20-minute program that replaces the standard warm-up. So it's not like they're really having to add much time onto their practice or to their day. It's just a different way to warm up. And there are 20 exercises, and it's done 2 to 3 times a week. So there's still days for kind of a more typical warm-up. And they base this program on athletes 12 years of age or older. So younger athletes, kind of the pre-puberty athletes, have a modified version that they recommend. And the nice thing about this program is the exercises, there's an online guide of them and they're free. The trick being, though, you can't just print this off and give it to your athlete. It's like I said earlier, it'll take a trained eye to make sure that they're performing the exercises appropriately. And you'll see too in some of the pictures, it says what the person should look like and what they shouldn't look like. But sometimes when it's a jumping or a cutting drill, like it's really hard to tell if your eye is not trained, you know, on what that moment should look like when they're cutting or when their knees turned in too much. So that's why it takes the skills of an athletic trainer for sure, or a physical therapist, to help these athletes do these specific programs correctly for them to actually do what they're supposed to do. The second one is different from the other two in that it's available online, but you have to use one of their certified trainers to be led through the exercises. So they're not just available. You have to sort of sign up with them, and they provide you either an in-person trainer or a virtual person. They're out of Ohio, though, so Colorado would need to use the virtual choice for that. And they're certified trainers. As physical therapists, we can be trained. Athletic trainers, and they combine these virtual visits with sort of the same kind of warm-up program that the athlete would do on their own. It's not like you're meeting with the trainer virtually every single time. It's meet with them once, learn the phase one, do them, kind of having someone watch you, or you can pay for more virtual sessions if you don't have a trainer or a PT that can take you through them when you're not working with one of their certified trainers. The good thing about this program is if you wind up working with them, they have a test that you have to sort of pass before you can go on to the second or third phase. So they report that it assists in reducing the risk of serious knee injury. And obviously that article from the orthopedic surgeons backed this program as being one of the two that they found that really prevented the injuries of the athletes. And then the final one is the FIFA 11 Plus. And this is very similar to the first one we talked about, the PEP, because it was also based on exercises for soccer players. Same thing though, the exercises kind of can carry over to any sport that uses jumping or agility as part of what they're doing for their injury prevention program. The key elements of this program, this is going to kind of be redundant, are the same. It's core strengthening, neuromuscular control, which Lizzie mentioned is also good for the ankle, the eccentric hamstring strength. That might be a word you're not so familiar with, but it's just the way that you can make the hamstrings, train the hamstrings to sort of engage as the knee is straightening in relation to the ground. And then they also should have some kind of a plyometric and agility. They have a plyometric and agility piece also. They report that consistent implementation of the 11 Plus can lead to a 30 to 50% reduction in the knee injuries. The website at the bottom again shows some of the actual manual for this. If you copy and paste it into your browser, the manual for these exercises and how to progress them with someone that sort of has a trained eye on how to make sure the athlete's doing them correctly. And I have some pictures here that are consistent with the FIFA 11 Plus exercise progression. The nice thing is there are correct and then sort of incorrect performance of the exercises. So again, if you look over on the one on the right, like it's hard to kind of tell just if the athlete's doing that exercise pretty fast on if their knees are doing what they're supposed to. So it's good to have someone kind of watching over and making sure those little subtle differences that you might not notice on the top row compared to the bottom row aren't happening. So the athlete isn't training themselves in positions that aren't really helping them in the long run.
So that's it for us. If you have any additional questions or want more information about injury prevention programs, we're more than happy to share that information with you, with your athletic trainers or with your coaches. Here you can see Karen and my contact information. You can also reach out to Kevin Roberts, who is our athletic trainer for District 20. He has lots of information about injury prevention as well.
Thank you.
Thank you very much.
Mm-hmm.